Hi, I am Tuthall. I'm one of the co-directors of Hyp+Access. I lead our educational initiatives, communications, and internal nonprofit administration.
Hi, my name is Audre Wirtanen. I'm one of Hyp+Access's co-directors, and I'm leading the development and launch of Hyp+Care. Today, we're talking about how Hyp+Access's approach differentiates us.
To donate to Hyp+Access, please visit hypaccess.org/donate.
Hyp+Access has identified an urgent healthcare crisis. Can you give a quick overview of the crisis as you see it?
There are many complex chronic conditions that are pretty wholly unserved within the current medical system. And I would say globally, not just in the United States. Some of the main conditions that we identify as being really unserved include connective tissue disorders, including hypermobility spectrum disorders, dysautonomia, fibromyalgia, mast cell related disorders, myalgic encephalomyelitis or chronic fatigue syndrome, long COVID, and other infection associated chronic conditions. And the list really goes on. All of these conditions are multi-system and multi-symptom, and they show up together, they co-occur together, and they need comprehensive, coordinated primary and specialty care and access to alternative care because there's really no care that has been developed for any of these patients at any price point. So many people who also have access to resources are unable to get any care. These patients tend to cycle through specialties and they see many, many people without getting any kind of services or any kind of answers. There's unnecessary assessments they're going through, misdiagnoses, mistreatment, and a very large emergency department utilization because there is no other place for them to turn when they need things. And then things are unaddressed for a long time until we are in an emergency situation. And that costs not only the patient far too much money, but it also costs the healthcare system far too much money. All of these conditions are severely underdiagnosed. They're all common, none of them are rare. And this is in part because clinicians are overworked and undersupported in serving these patients, particularly in a COVID impacted context. So the system itself is not set up to serve people with complex chronic conditions that have been biased against for many, many years. And these patients face many barriers, not just financial, but other kinds of bias and insurance barriers as well. On average, these patients are facing a 4 to 22 year time gap in actually being diagnosed. A lot of times these patients fall more on that 22-year side. It's pretty rare for somebody to get a diagnosis within 4 years. That's definitely a feat and relates to their access to care. Folks have an average of 10.4 diagnoses before getting the main diagnosis that they really identify with, and an average of about 3 misdiagnoses within that 10.4 diagnosis group. Their quality of life is comparable to congestive heart failure and later stage cancers. So these are very impactful conditions that disable people, that make it so that they cannot do the things that they want to do. They cannot take care of themselves the way they want to take care of themselves. They're unable to maybe take care of other people in their life as well. And there are really high rates of co-occurring mental health conditions and suicidality. So the majority of these patients are suffering without diagnosis or care and with little hope for treatment within their lifetimes. And if we think more systemically about the care crisis and not the patient base that's being unserved, we know that there's no comprehensive care anywhere at any price point globally. These conditions are severely underdiagnosed and very poorly served within a current medical system context. Patients are facing bias and barriers, particularly for patients on state insurance or who are underinsured or who have identities that are more biased against. Clinicians are overworked and unsupported in treating these patients, in trying to provide for these patients, because they require more time, collaboration, and resources, and health systems are overwhelmingly going towards shortening appointment times, using less resources, moving faster. These patients actually need a lot more time and resources. And there really are no long-term solutions that exist, let alone are scaling to meet the demand of this massive patient population that is unserved.
I will add that our history of working with people in these interconnected communities is really, we've had an emphasis on people who are not diagnosed, on people who have a lot of these identities that physicians and systems may be more biased against. And so many people in this community have no diagnosis at all, or they have diagnoses that are not even close to getting them care, are really, really off base, and are not getting them any of the resources that they need, especially people who are on Medicaid or lower tier insurance plans. And that's really not a focus that any of the other groups out there who are kind of attempting to address parts of this crisis are acknowledging. So there are some places out there that, in quotes, specialize in some of these diagnoses, but they're not looking at the broad picture, and they're not thinking about the folks who are not diagnosed at all, are completely misdiagnosed, and cannot access specialty care because of their insurance or their poverty levels.
You've talked a little bit about some of the diagnostic categories that make up highly complex patients that you work with. For those who may not already know, can you give us a sense of what sort of highly complex patients you work with and how common their conditions truly are?
Yeah, so Hyp+Access in our clinic, Hyp Care, focuses on many, many complex chronic diagnoses, which result in multi-system, multi-symptom problems throughout the lifespan. They're all interconnected. There's no rhyme or reason for an order in which someone develops them. You can develop them in any order at any time. And what's really important to note is that none of them are rare, but they've all been pushed into rare disease charity research models, which is very limiting in the way that the system views these conditions and how to support people with these conditions. The statistics are largely because of bias in research, and a focus on rarity without any evidence. And a lot of expert consensus has carried that very unfortunate perspective with nothing to back it up. So we consider all of these conditions to be Hyp conditions, and we use that term very broadly to encompass all of the experiences, because anybody can experience any part of it at any time, and there really is no hierarchy. They include connective tissue disorders, which includes hypermobility spectrum disorders, Ehlers-Danlos syndromes, mixed connective tissue disease, lupus, Sjogren's, rheumatoid arthritis, scleroderma, and many more. And these impact around 1 in 5 people. This is from data where people did not come in with a diagnosis, but were screened. Infection-associated chronic illnesses are also in the Hyp bucket. These include myalgic encephalomyelitis or chronic fatigue syndrome, which impacts up to 18% of people, especially as COVID has increased the prevalence of this condition in particular. Long COVID, which impacts 1 in 3 in New York State. And there was a statistic that recently came out indicating that globally long COVID is impacting 36% of the population who has been infected with COVID. And as a reminder, COVID is continuing to circulate in our communities with hundreds of thousands of infections a day. Mast cell activation syndrome is a big part of this interconnected pot, which impacts up to 17% of the population. And fibromyalgia and chronic pain disorders, which impact 4% of the population, although I think this statistic is quite old and we could do some rescreening on this. And dysautonomia is a really important one, which really connects all of these conditions together. Most people develop dysautonomia as a co-occurring problem. And this impacts up to 30% of people. And this is also largely because COVID infection has really drastically increased the prevalence of this condition across people. A case study of a person that might be a Hyp. They might be diagnosed with hypermobility spectrum disorder, postural orthostatic tachycardia syndrome, and long COVID. And they have body-wide symptoms associated with these diagnoses like chronic pain and fatigue, but also have serious gastrointestinal and allergy complications that go undiagnosed, and then develop serious neurological complications like a cerebral spinal fluid leak that go undiagnosed. And so we have this partial pot of diagnoses with a lot of overlap in symptom sets across the mechanisms that are co-occurring simultaneously. And it's really about peeling back those onion layers to understand what is really causing what and how to best get at improving somebody's quality of life. when we think about this invisible epidemic, we're thinking about a huge population with unmet needs, with huge diagnostic delays. And what's important to know is that all patient subtypes can develop all of these other conditions comorbidly in all directions. There's no, again, rhyme or reason in terms of who develops what in what order. All of these diagnoses are lifelong and require comprehensive multi-specialty care. All of the specialists actually end up seeing all of these patients, even if they only specialize in one diagnostic category. And that's because these conditions occur together. And the majority are really looking for ongoing support and treatment in their lifetimes. And even if they find a diagnosis, that continued support is very, very rare.
We do know how to treat these populations. I think a really common misconception in communities and a common opinion put forward by a lot of these experts is that we don't know how to treat, and we need to do further research on the molecular cause of these things in order to treat. But those treatments are out there, and they actually do apply to all these different diagnostic categories, but people can't access them because the connection between things is not being considered, and care access itself is not being prioritized above molecular and genetic research. So we have this situation where people are relying on a lot of really insular, really small sample size research as the kind of hope for care in this community, in these interconnected communities. But people are suffering and dying right now without care. And that's really what we focus on. I'll also add that a huge problem in this research, as Audre was alluding to, is how reliant it is upon people being diagnosed already. And a lot of the data that we look at is data that doesn't do that, that screened populations in other ways for symptom sets. So we can actually see who is experiencing this rather than who is happening to get a diagnosis through privilege, luck, different access to different specialties. So a lot of the data that these so-called experts in the community, people who are maybe really large and have quite a bit of funding, a lot of what they're focusing on in their data is the people who already have access to diagnosis, already have the most access to care, even if their access to care is absolutely terrible. So we really need to move beyond that and look at what people are experiencing rather than what they've been able to access.
Can you talk about how being made to feel that symptoms are quote unquote all in your head impacts people in this situation? And how does it show up in medical care settings?
Sure. So this all in your head business, from our perspective, is a direct consequence of this false rarity narrative, of these problems that are so baked into our medical system that are really the way it's designed. It's designed to prioritize profit over people, to prioritize specialty research over immediate care for people, and to continue ignoring the massive commonness of these interconnected conditions. So because these conditions have been considered rare, because they've been so massively neglected, there is such a scale of neglect and such a scale of misconceptions and misunderstandings about them that it's really beyond words, and beyond numbers, because the people who have been neglected in these ways are not caught in that data because they probably weren't diagnosed with these things, right? So this is really a central problem in these communities, people being dismissed, people being misdiagnosed, people being told that what they're experiencing is not real. This all in your head line that, frankly, almost everyone in this community experiences, whether that's a few times or constantly. And the consequences of that can really, really range in severity, but they are really significant. People get told it's all in their head. People get misdiagnosed with psychiatric diagnoses when they're actually seeking care for physiological symptoms, just because that's the response of not believing these conditions are common, not understanding these conditions, and also physicians not having the education or resources they need, as well as the biases that they may hold as individuals. So people get misdiagnosed, people get dismissed, and this can have consequences ranging from them receiving no care to them receiving totally inappropriate care that damages them permanently, to them being psychiatrically incarcerated or institutionalized, to even them dying from care neglect or mistreatment. So this is really a core problem in this community, so much so that almost everyone who works with any of these diagnoses is aware that this all in your head thing is a problem, but they may not understand the reasons, and they may not understand the scale and how frequently this is happening to people and keeping them out of the diagnoses that might get them the most access to care within this already terrible system. For us, we start from a place of believing what people are telling us, believing what they are saying about their own experiences, their own symptoms, not making assumptions that they don't know what they're talking about, or that that couldn't possibly be happening because it's too rare or because it isn't connected to this other diagnosis they have when it truly, truly is. So that's the place that we start from. And what we think is the most important here, rather than imposing this idea of what diagnostics are and what conditions are, starting from the patient experience and believing them from the onset.
We believe that the patient's experience is actually the most relevant and most immediate and most accurate form of information that we can gather. Because without understanding what their experience is and what is bothering them and what is causing them significant disruption in their daily life, we cannot effectively approach their needs. So I always like to say that every client that we have ever had was able to verbalize what was going on in their body, even if they didn't have the exact medical language, prior to anybody taking them seriously when they were trying to initially get care. And then they were gaslit out of that experience. And people tend to develop patterns of dissociation, which can be very protective. Dissociation is not always bad, but it does make it difficult for somebody to then know, well, what are my limits in my daily life? And what does it mean when I push too hard and then crash? And how can I take care of myself? And it creates this situation socially where people are essentially told, you just need to push harder because your thing isn't real. And it's something that is wrong with the way you're experiencing yourself in your body, rather than there's something really seriously happening here that we need to address. And so it takes years for patients and people to reconnect with their experience as truth. And that's something that we uphold as number one.
And to add one thing further off that, this problem ends up reflecting back into diagnostic data and into research data, and then reinforcing this problem. For example, someone diagnosed with hypermobility spectrum disorder, which generally has lower care access than hypermobile Ehlers-Danlos syndrome diagnoses, they may be told over and over again that they can't be experiencing these other things they're experiencing because there's a misconception that hypermobility spectrum disorder only impacts the musculoskeletal system or the joints. So then they may stop believing themselves in what they're experiencing and not even report the things they're experiencing in different research data. And that can skew things further and make it seem to researchers and to the community like this condition is less severe or is less systemic throughout the body, which is absolutely untrue. This gaslighting and this, what we call psychiatrization of people's symptoms, is incredibly harmful, and we need to believe people.
People can have psychological or psychiatric things going on simultaneously, and that should never discount any other experience that somebody is having. And the way that it shows up in medical care is that psychiatric condition is a stamp on your chart that leads other doctors to often not even see you. They won't even take you in their office because you have this stamp of psychosomatic disorder, whatever it is, psychiatric issue, and it makes it so that doctors who specialize in physical problems will not take your physical problems seriously. And it creates huge care gaps that push people into emergency departments over and over and over again.
For example, here in New York, people with psychiatric diagnoses like bipolar or psychomatic diagnoses like somatization or conversion disorder are refused at most clinics that deal with neurological complications of connective tissue disorders. So they won't even be assessed for things like cerebrospinal fluid leaks just because they're diagnosed with something like bipolar.
Even though the symptoms that cerebrospinal fluid leaks and neurological conditions in these populations cause are the same symptoms that have been categorized as psychosomatic. And so it creates this total unwillingness to recognize these symptoms as physical when they absolutely are.
Patients often feel like they need to hide their psychiatric experiences, which are often the result of the trauma they've experienced in the medical system, combining with many other factors and just the way that they experience the world. But this false conflation that medicine does with physiological symptoms that they just don't want to deal with hurts so many people.
Another reason that connective tissue and co-occurring condition symptoms are pushed into the psychiatric pool of medicine is because there has been no real understanding of basic connective tissue physiology applied to medical school and specialties and clinical understanding. So it is really frustrating to us when people talk about, for example, mast cell as not a connective tissue related problem, when mast cells, which behind L and I are these pink large cells, are actually an essential component of connective tissue. They are a connective tissue cell. So there's just a base misunderstanding or lack of understanding of basic cell knowledge within these fields, which leads doctors to think these things are totally disconnected from each other, not real, and doesn't think about the interplay of all of these pieces together. And it's also important to note that stress and mental health play a role to a degree in things like chronic pain, chronic fatigue, and physical symptoms, but stress makes everything worse, right? Stress can turn a cancer gene on. Stress can make your colds worse. Stress can make your stomach ache worse. Stress can make whatever you're experiencing worse. And oftentimes with conditions like these, which are quote unquote mysterious, even though they're really not, it's just people don't really want to learn and expand their understanding. What happens is they then get put into, oh, well, your stress is then the cause of all of your problems. And it can be a factor, it's a compounding factor, but it is not really the cause. Stress could be a cause of diabetes too, but we don't say that diabetes development is all in somebody's head. To donate to Hyp+Access, visit hypaccess.org/donate. Thank you so much.